Hello everyone, this is Dr. Hassan Mustafa from Department of Pharmacology. Today we will talk about factors affecting drug response. Later I'll be meeting you again for toxicology lectures. So what is our subject today? We'll talk about variation among patients, why patients differ among each other in response to a certain drug, why individuals are different in their response. We will try to take these factors into consideration, and then while we prescribe a medication, we try to mitigate differences and give an ideal treatment regimen. These factors are classified into patient-derived and drug-derived, as well as some other miscellaneous factors. Drug-derived would be the dose regimen, route of administration, formulation, and gastric emptying. Patient-derived would be compliance, body weight, age, etc. And some miscellaneous factors like placebo effect, drug tolerance, and drug-drug interaction. So we start with drug-related factors. First would be the dose regimen. The dose regimen, what is the interval at which we apply the medication? How much we are giving this tablet? How many times a day? And every single dose, how much we are going to give? Are we going to give 1 gram of paracetamol or 500 milligrams? And why? First, it depends on the knowledge of the pharmacokinetic behavior of the drug. To decide on the appropriate dose and dose regimen, ideal regimens should maintain therapeutic concentration in the blood until treatment is achieved. So this is a typical drug concentration in the plasma curve. For example, upon oral administration, the drug starts from 0, it starts to get absorbed, and then its concentration gets higher and higher. In the same time, metabolism and excretion start reducing the drug concentration in the blood. So we reach into a peak, and then below certain level, the drug is not yet effective, below the therapeutic window, and above certain level, the drug is toxic. Between the non-effective and the toxic, we have the effective window, the therapeutic window, where the drug is exerting the desired effect. Repetition of this pattern would lead to this fluctuation. We don't like fluctuation generally. We need the drug to stay in the therapeutic window as much as possible. We don't want to give it to an extent that it will have toxic effects, and we don't want the drug concentration to fall below the therapeutic effect. So this we define as steady state. Usually is defined that after 4 or 5 half-lives, where the concentration, after 4 half-lives means at 5 half-lives, where the concentration is as steady as possible, not fluctuating much, and all in the therapeutic window. So the steady state concentration is always proportional to the dose. The more the dose, the higher the drug concentration to the interval, the more the repetition, the higher the steady state concentration, proportional to clearance also. So the more the clearance, the less the steady state. It is also proportional to the percentage of the drug absorbed. More absorption, more steady state concentration. So if we want, for example, to administer theophylline and reach a steady state concentration of 10 milligrams, ideally 10 milligrams per liter in the blood. We can either administer IV and monitor and then get the steady state concentration into 10 as we see in the black line, or we can give it once daily at a dose of 672 milligrams. So see the fluctuation between much high peak concentration and low concentration, or we can administer it 3 times daily and then get this fluctuation much less at a dose of 224 3 times daily, which technically is the easiest to follow among the 3 ways of application. I think you are familiar with routes of drug administration from pharmacokinetic lecture. So generally we divide them into systemic and local. So systemic, where the concentration is where the drug activity is aspired to be achieved through the systemic circulation. The drug need to go into the blood, then from the blood into the target organ, and this is divided into enteral from intestine, enteral administration through the GI tract, or parenteral, any systemic application that is not enteral, like inhalation, like in all types of injections. And we have the topical, local application, topical, like topical injection, local injections, or topical creams, or administration on the topical mucosa, for example, of the mouth, of the nose, of the rectum. So we remember that we have something called the first pass metabolism in the enteral routes, where drugs, majority of drugs that are given orally are absorbed through the intestine, basically the small intestine, and then they are forced to go through the portal vein into the liver. So all the drug is straight away going to its metabolism, excretion, elimination site, metabolism site. So this is a forced first pass that might cause the metabolism of many drugs. An example of that would be lidocaine, which is metabolized rapidly in the liver. Other examples would be opioids, analgesics, opioids and antibiotics that can be affected through first pass metabolism. So how to make a drug suitable for administration? Let's say I have a paracetamol powder and I want to give it to a child, or I want to give it to an adult. What is the easiest way to make it? One suggestion is just to glue it together. So I take this paracetamol and then I mix it with the glue, and then I press it and make it into a tablet, and we get paracetamol. The problem with this simplistic approach is that the drug is glued together. It won't come out. You will swallow the tablet as a whole, and it will get out from your body as a whole. The drug won't disintegrate. So what do we usually do? We make the dosage form. We formulate. That's a science by itself. We take that paracetamol, we mix it with certain ingredients. We call certain other ingredients, we call them excipients. So in an example of a paracetamol suspension that we give to children, we mix it with water and sugar and flavor, orange flavor, let's say, and we also add preservatives for it not to spoil. In the case of tablets, we mix it with other ingredients to form the shape of the tablet, like starch, and ingredients to make it disintegrate in the intestine, so it doesn't hold up in the intestine, but it holds up on the shelf, so it becomes stable on the shelf first. Now, this is a classification of dosage forms. Generally, so all these excipients, all these additions to the to make the dosage form, to make the tablet, to make the capsule, to make the injection, we call them, all these materials, we call them excipients. And with these excipients, we form the dosage form, and we control how the drug is released, how the drug is getting absorbed in the absorption site. An example of that would be Panadol. So when you go to the pharmacy, they will ask you which Panadol you want to take. For example, you want to take Panadol Actifast or regular Panadol. Why would you choose Panadol Actifast? And it's usually more expensive, more premium form of Panadol, because Panadol Actifast actually can release the drug content, the paracetamol, from it at a faster rate. So on a fasting with a glass of water, Panadol Actifast reach a much higher concentration, much more desired concentration in this case, at 25 minutes. While normal Panadol reach a high concentration at 45 minutes, and this high concentration is much smaller than Panadol Actifast. So a basic experiment, how to know if the Panadol that you are taking is good quality, or if you want to compare between Panadol formulations, put it in a glass of water. Let it disintegrate, let it release its drug, the drug content, and see how fast it does that. During my study as a pharmacist, one industrial lecturer used to give us this example of his own artwork. So this is a drug from my country, and he used to say that, look how nice this cough medication that I make. It has paracetamol in a dissolved form in this soft gelatin capsule, which will make it available for absorption very fast when the capsule is swallowed. A traditional tablet, as opposed to that, would first, as we saw in the GIF video before, it will disintegrate first into granules, and then the granules will go into smaller particles, and then these smaller particles will dissolve, and here this drug is already dissolved, and then the drug becomes a solution and then get absorbed. The choice of a dosage form is important for patient compliance. So, for example, when you don't have any choice on the dosage form, like in insulin, all dosage forms available are injectables. That's why patients don't like insulin. A lot of compliance issues with insulin. Here in Malaysia, you can realize that you go to see the elderly around you and ask them about their insulin treatment and see. Also an example, let's say two antibiotics, normal amoxicillin, which need to be given 4 times daily, and augmentin, amoxicillin with clavulanic acid. Normal amoxicillin need to be given 4 times daily, while augmentin is given 2 times daily only. So which one is easier for the patient to be compliant with? Of course, the lesser times of administration is better. Another factor that is patient related is gastric emptying. Gastric emptying is the movement in fasting patients occurs once every around every 1 hour. The stomach will open into the duodenum and empty its content. So that would be the gastric acids. So when you ingest a tablet with an empty stomach, you expect that, or a small amount of liquid, a syrup, you expect that it will go down once every 1 hour. You expect 1 hour delay. If you get 1 glass of water with it, you get this time into 15 minutes instead of 1 hour. Now, if you take it with food, that is a whole different kind of worms, whole different problem. When you take the medication with food, the gastric emptying can vary between 30 minutes and few hours. Depends on what type of food is that. So it is important to note that fatty food in particular prolongs the gastric emptying and is not favorable for the absorption of many drugs. However, in some cases, in important cases, gastric emptying can be essential for absorption, for example, of fat-soluble vitamins. That's why you can consider it a scam when the industry, the dairy industry, asks you to drink milk skimmed from its fat, because the fat actually contains the fat-soluble vitamins that are important, and it helps in absorption of fat-soluble vitamins. Now we move into patient-related factors. We start with compliance or adherence, how much the patient accepts the drug and is willing to take it. Can be called also capacitance. Is the degree to which a patient correctly follows the advice. Reasons for non-compliance. There are so many reasons for non-compliance. Might be lack of understanding of the drug. Nobody explained enough for the patient what the drug is about, what its purpose, why it was prescribed for them, how it is administered. They don't know how to take the drug. You give the patient, for example, a cream. You need to tell them how much of the cream they need to put on the lesion, for how long they need to rub it. You give them an inhalation. You need to tell them how to actually put the inhaler in the mouth, how long they need to hold their breath, how they are going to breathe while inhaling the drug. It might also reflect on socioeconomic factors. Poor patients, of course, less compliant with medications, negative feelings toward the drug or the prescriber. So when people don't trust pharma, don't trust the healthcare system, don't trust the doctor, so they don't like the doctor, they think that, for example, the pharmaceutical industry is ripping them off, or they think that, okay, natural drugs are always better. They don't trust the healthcare system. Those are very important factors. Actually, drug adherence, drug compliance reflects on the quality of the healthcare system and the trust between the patient and the healthcare providing. Also, one important reason would be adverse reactions that are coming from the drug, so the patient doesn't want to take them, or simply patients forget. They are busy, or they don't care enough to take the medicine on time. Sometimes they just think, okay, my blood pressure is now controlled, no need to take the drug anymore. I will just exercise. Or sometimes they don't know, they don't notice the difference. They don't touch the difference. For example, in some serious chronic illnesses like hypertension, it takes 3 weeks in hypertension for the drug to have a steady effect. A chronic tuberculosis, for example, is a very long treatment regimen. In hyperlipidemia or hypercholesteremia, people don't tangibly feel the effect of reducing their blood cholesterol. You have to explain to them that, okay, this reduces cardiovascular events, reduces the chance of you getting a stroke. Side effects we talk about. Deviations in self-administration tend to increase progressively. Also, people get by time they get bored of taking the drug, even though it works, even though they know it works. The more complex the therapeutic regimen, patients have so many drugs to take, so it helps them getting bored of the treatment. Very important to focus on the doctor-patient relationship and the healthcare patient relationship, the pharma-patient relationship. Always effective communication. Talking to your patient helps promoting compliance. And this is an important role that can be tasked to healthcare providers other than physicians. So a lot of research always published from Malaysia about adherence. We have a very serious problem, I think, and I personally is making research about diabetic patients. There are people who also prescribed hypertension medications that they don't take them even at young ages. Another factor would be body weight and body composition. So you can define 18-year-old or 17-year-old person that is 42 kilograms, 40 kilograms as an adult, and in the same time you can define someone that weighs 150, 160 kilograms as an adult. These two patients differ significantly in their overall weight and in the composition of that weight, the ratio of adipose tissue to muscles, lean body weight. Two patients with the same weight can be different in that composition also. So a gym rat is different from a chat time rat. Drug clearance is greater in obesity and correlates with lean body weight. It is important to note that drugs are secreted in the hydrophilic form. Clearance is correlated to lean, then adipose weight, so adipose tissues can hold on to drugs that are lipophilic, and this will lead to delayed clearance, and then the drug can be reintroduced to the blood again. It hides in the adipose tissue for some time, and then it comes back, and this is called drug redistribution. I think you are familiar with the concept. How to mitigate? This usually we look at we do something we call therapeutic drug monitoring. That means we measure the concentration of the drug in the in the blood at certain interval with the administration. Examples of drugs that hide in the tissues would be opioids and general anesthetics. So here is a list of drugs that require adjustment in obesity and how to do the adjustment. So some drugs we just follow the clinical response, no need to monitor concentration, and some drugs it's not enough. For example, here the low molecular weight heparins are blood thinners. They are sensitive. Digoxin has a very low therapeutic index, very small, narrow therapeutic index. Same for phenytoin. It's a toxic drug, so we need to measure the serum concentration of phenytoin. Another important factor would be age. So pediatric patients generally cannot be given adult doses. Children are not small adults. Children differ in their metabolism compared to adults, and we have generally two categories of children. We have neonates, newborns, and we have children above 6 months of old. Neonates are more sensitive, so they need less concentration of drug per weight, smaller milligram per kilogram compared to adults, while children usually need larger milligram per kilogram doses because neonates don't have hepatic function mature yet, while children has higher metabolism rates, so they act as per body weight. You give them larger milligram per kilogram. Those adjustment relates to body surface area and body weight. So body surface area is important for highly toxic drugs like anti-cancer drugs. We don't use body weight for such drugs to correlate. It gives a better indicator for on the difference of age. However, at the end, those recommendations are always follow clinical trials. They are evidence-based. There is no calculator that can give you the dose for a child from the dose for adults. It needs to be evidence-based. On the other side of the spectrum, we have geriatric medicine, treatment of the elderly. They are hyperreactive to drugs because of lower kidney function at older age. Generally, older age is considered after 65 years of old. So schedule need to be adjusted towards lower doses. Another consideration would be disease state. And disease state can affect pharmacokinetics and pharmacodynamics of the drug. So therapeutic drugs are prescribed to patients effects of the disease. So effects of disease on drug response are important, especially disease of the organs responsible for metabolism of and excretion. So diseases can cause both pharmacodynamic and pharmacokinetic variations. Usually diseases that affect renal and hepatic function can affect ADME, can affect metabolism and excretion. Absorption for oral drugs can be affected by diseases in the gastrointestinal tract, for example, Crohn's disease, malabsorption. Diseases of the pancreas. Nephrotic syndrome alters drug absorption because of edema and intestinal mucosa of the intestinal mucosa. Which leads to changes in protein binding. This causes insensitivity to diuretics like furosemide. Other disorders affect the sensitivity by altering receptors and signal transduction mechanisms. So on the pharmacodynamic side of things, diseases influence receptors like myasthenia gravis, which is a disease that affects the muscles, particularly the neuromuscular junction, the interface between neurons and muscles, where those are nicotinic receptors to acetylcholine. You will study them in more detail soon. So the sensitivity to a neuromuscular blocking agent, so an agent that blocks acetylcholine receptors, nicotinic receptors, may influence the neuromuscular transmission. An example of that would be aminoglycosides, which are antibiotics. Familial hypercholesterolemia, which is a form of increased blood cholesterol that is hereditary, and it is more dangerous than the standard, more common hypercholesterolemia that we all are familiar with. Those patients are not affected by statin treatment. Statins are not effective with them. Diseases that influence signal transduction. So examples are pseudohypoparathyroidism, affects coupling of G proteins. Now let's move to genetic predisposition to variation in drug action. This is very important, and understanding it is essential for advancing medicine. So genetic predisposition, genetic variation among patients is a very important determinant of the drug response. All pharmacokinetic and pharmacodynamic parameters are affected by genetic factors, transporters, metabolizing enzymes, receptors. After the receptors, second passenger pathways. So the pathway of the drug inside the cell are all controlled by genetics that make the proteins that handle the drugs. Complex traits may not be Mendelian, it's not always hereditary. They are additive factors. Multiple genes can be in effect. Environmental factors can be also in effect. And we can define here two important terms. One is pharmacogenetics, so which is the science, the study of genetic differences that can cause variations in drug response. And pharmacogenomics. Genomics is wider than genetics. Is a study of the particular influence of genetic variations in drug responses. How we correlate specific differences in genes that comes down to single nucleotide polymorphisms, SNPs, SNPs. Every single nucleotide difference, what is its effect on the drug response? So variations in genetic makeup of individuals lead to different metabolizing enzyme subtypes that have different levels of effectiveness. So for one particular drug, for a certain drug, we can expect that there are people who have slow metabolism, so a drug is metabolized slowly, which leads to accumulation of the drug and risk of toxicity. The same drug we might have on the other side of the spectrum, fast metabolizers, people with enzymes that process the drug quickly, which leads to fast elimination of the drug, and then we cannot achieve a therapeutic level of the drug. So one major example that we use a lot is a drug that is used for the treatment of tuberculosis, which is called isoniazid. So it has both categories of fast metabolizers, slow metabolizers, and intermediate metabolizers. So we need to decide, and isoniazid can have toxic effects, and it needs to be used between 6 months to a year or more than a year. So it's very important to know and to monitor the drug response. Now let's move into miscellaneous other factors. So we talk about psychological factors. You all know what is a placebo or a placebo effect. We have to differentiate between the definition of a placebo and the definition of placebo effect. A placebo is an inert substance that is given in the context of clinical trials. So it's not something that we use clinically. We don't use a placebo to treat patients. We use it in the context of clinical trials, in research. It works by, we use it to eliminate the psychological factor. So how it works, how it gives a positive pharmacodynamic effect, we call it psychodynamic rather than pharmacodynamic. The efficacy can be affected also. It varies between patients. It can be affected by patient beliefs, attitudes, expectations. Substances used as a placebo can be lactose tablets, capsules, or distilled water for injection. And in the opposite, we have the nocebo effect. That means the absence of a drug, when the patient feel that there is no intervention given to them. For example, you are mixing the drug with food to your patient, so they don't know that they are taking the medication. It is now let's move to drug tolerance. Drug tolerance refers to the requirement of a higher dose of a drug to produce the given response. So it's a common concept. People relate to it a lot. Okay, I'm taking this medicine for a long time and it's not effective anymore. It can be classified into natural and acquired. Natural drug tolerance is the concept where individuals vary, so some patients don't get effect of the drug simply. Acquired is by the repetition of the usage of the drug. The effect gets less and less. Tolerance can be tissue specific or organ specific. So tolerance can happen in some organs and not happen in other organs in the case of a drug that exerts its effect on several organs. For example, morphine produces tolerance on the euphoric effect, but it doesn't produce tolerance in the effects on the GI tract or on the pupils. That's why drug addicts who are addicted to morphine, they will get less and less euphoria, less and less joy of getting the drug by time, but constipation will still be there. So if they increase the dose, they will have more constipation. And the effect of the pinpoint pupil also is not affected by tolerance. So they will be easily spotted taking the medication, more easily spotted by noticing their pupils that are constricting. An important concept in tolerance is called cross tolerance. Sorry. Cross tolerance is the tolerance of a drug because of usage of another drug. The two drugs have to be in the same class, in the same tree of drugs, in the same group of drugs. They have to be chemically related and working on the same receptors. So, for example, in the same way of work. An important example is benzodiazepines. So if you are taking a sleeping aid like alprazolam, and then you need an anxiolytic, another benzodiazepine like diazepam. So if you're taking alprazolam for a long time, and then you need to take diazepam, you are expected to need higher dose of diazepam because you already developed tolerance to benzodiazepines through alprazolam. However, that doesn't make you tolerant to another group of drugs that are used before as an anxiolytic also and sleeping aids, which are phenobarbiturates, like phenobarbital. So barbiturates, different barbiturates can cause tolerance to each other, but they don't they don't cause tolerance to diazepam and benzodiazepines, and vice versa. Now we talk about drug-drug interactions. So many patients that come to the clinic to seek a treatment for a condition, they have other underlying conditions, different other conditions, other diseases. Like common ones would be diabetes, hypertension, heart failure, osteoporosis, and they are taking medications for these conditions. Acute events require additional treatments. So if a patient with a heart disease had a stroke, then they will have additional treatments. So those account for a heavy percentage of drug-drug interactions. Approximately 30% of drug reactions are estimated to be due to drug interactions. That's why systems are put in place. We call them, for example, pharmacovigilance, to report adverse drug reactions. Drugs can interact with other chemical entities other than other drugs, so any substance can cause interactions. An example in food would be grapefruit juice, which downregulates certain cytochrome B450 enzymes and leads to toxicity of some drugs. So the administration of one chemical entity can alter the action of another, both in pharmacokinetic ways and pharmacodynamic ways. Examples of pharmacodynamic interactions would be the interaction between beta receptors, and beta agonists. So beta receptor antagonists and beta receptor agonists. Beta receptor antagonists like propranolol will diminish the effect of beta receptor agonists like salbutamol. One is used for for heart problems. One is used for asthma, and then taking propranolol will reduce the effect of salbutamol on asthma, which can be dangerous. Another famous example would be sildenafil, is the drug that is used for erectile dysfunction. It works on certain cyclic GMB, second passenger. I think it's type 5. Yeah, type 5. And this cGMB actually is found in the arteries of the penis. However, there is another cGMB that is in the heart, in the arteries of the heart. I think cGMB1. And so while it causes vasodilation in cyclic GMB5, it also can cause partial effect on cyclic GMB1. This would cause interaction, exacerbate the action of other drugs that are used to cause vasodilation in the heart, like nitrate, organic nitrate, nitroglycerin. So this will exacerbate the action and cause serious hypotension. Another example would be the increased risk of bleeding caused by warfarin when you are taking medications like aspirin. Both are blood thinners in different mechanisms. And a very important example is very important is the non-steroidal anti-inflammatory drugs like ibuprofen, indomethacin, diclofenac, aspirin, that inhibit the biosynthesis of prostaglandins. So in patients receiving a treatment for hypertension, this will increase their blood pressure. In patients getting treatment for peptic ulcer, this will cause the peptic ulcer to be exacerbated. For pharmacokinetic interactions, all ADME pharmacokinetics, absorption, distribution, metabolism, and excretion can be affected. Also, if we talk about, I think you studied enzyme induction in and inhibition in pharmacokinetics, so a bit of a reminder. Enzyme induction can happen in genetic pathways. It is slow and it can get it takes time, difficult to spot. So drugs can induce the metabolism of other drugs, causing them to fall below therapeutic dose. Which leads to decreased effect, increased toxicity. Enzyme inhibition, on the other side, is directly happens by the drug inhibiting the enzyme effect, leading to higher concentration of the drug in the blood, lower metabolism of the drug. There are many examples. This leads to increased efficacy, increased duration of action, increased toxicity, and increase of drug-drug interactions with other drugs. So with this, we come to the conclusion of this lecture. Thank you very much for listening, and if any questions, don't hesitate to email me. Thank you very much.